of the year. Thank you. Recording started for that's going to be about pathology in hip with trisomy 21. And so again, there's lots to cover. I'm going to go ahead and do a little bit of housekeeping here for the kickoff, and then we'll get started. I'll pass it over to Dr. Thacker and the rest of the speakers to carry us through the webinar. So first thing is a quick land acknowledgement. The Hip Hop Network's grateful to operate in part on the current unceded traditional and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and we invite you all to reflect on the current traditional and ancestral territories, land, and waters which allow us to work, live, and play, and the same for you. I do want to mention the webinar is being recorded and ask that people please use mute as default, and we'll manage questions if you can enter them into the chat. A disclaimer is that this webinar reflects the opinions, interpretations, and insights of the respective authors and presenters, doesn't necessarily represent the views, policies, or practices of the Hip Hop Network. The webinar is intended for informational, educational purposes only, not intended to be specific medical advice, and we recommend consulting applicable local practices, guidelines, and regulations to determine the relevance and applicability of the content to your specific circumstances. And by participating, you acknowledge the Hip Hop Network and its presenters shall not be liable for errors or damages arising from the use of the content. And you expressly waive any claims against the network and its presenters. And your participation in the webinar signifies your understanding of an agreement to these terms. So with that, I'll jump right in. We've got, again, a very full agenda for this special topic. The first thing I'll do is introduce a short video by Dr. Kishore Murpuri, one of the co-founders of the Hip Hop Network. He's in transit today, so unable to join, but he did share a brief video that will help kick us off. So with that, I'll go ahead and Denisha, if you can go ahead and share the video.
Good day, everyone. I'm Kishore Mulpuri. I'm one of the pediatric orthopedic surgeons here at British Columbia Children's Hospital, Vancouver, Canada. I'm also professor and head of orthopedics at University of British Columbia. Thank you all for joining this webinar in person, or if you'll be watching this recording later on. We have over 130 registrants for this webinar joining us from different parts of the world. Today's Hip Hop Network webinar is about trisomy 21 hip. This is a very important condition that affects children with trisomy 21. As you can see in this esteemed panel, this is an incredible group of pediatric orthopedic surgeons with a vast experience in this problem who have published on this condition quite extensively. And their collective wisdom is going to help us to understand this better. We're also starting a registry on trisomy 21 led by Dr. Mihir Thacker very soon as a part of an effort to study rare hip conditions. We have the Hip Hop Network started a few years ago with a vision for a future with a solution for every hip challenge. The real mission for Hip Hop Network is to improve hip health and mobility and improve the quality of care for children with hip conditions worldwide. As you can see, the leadership is comprised of people coming from different parts of the world. Please see the QR code to join the Hip Hop Network. The Hip Hop Network has really been involved in a number of different efforts. As you can see, the annual meeting, webinars, Hip Health Day, online research resources. Please do follow us. There are links, different ways that you can get involved with Hip Hop Network. And lastly, very important message for you is to join us for our in-person Global Pediatric Hip Symposium. This is really bringing expert groups, patients and families for around the world to come together to really advance the pediatric hip care. All of the panel members today are attending this meeting. I'm looking forward to seeing as many of you as we can to welcome you to beautiful British Columbia and Vancouver in September. and look forward to seeing you all. We have kept the registration really low so that we can have as many people as we can participate in this event. Looking forward to seeing you all in Vancouver. Enjoy the great webinar. I'm looking forward to connecting with as many of you as we can. Thank you.
Okay, thank you, Denisha. With that, let's go ahead and jump in. I'm going to pass it to Dr. Mihir Thacker, who organized this terrific webinar. Dr. Thacker.
Thank you, Joel, and thank you, Kish, even though you're not physically able to join us today. But thanks for this opportunity for being able to discuss something that is a significant issue in pediatric orthopedics. It happens to be one of the unsolved challenges, so to speak, in hip pathology. This is a situation which is commonly seen by all of us. You have a 5-year-old with Down syndrome presents with a limp. You look at the x-rays, say, okay, that doesn't look too bad. But then when you evaluate them, you can clearly see that the hip is unstable. So the goal for today is for us to get a sense of what the spectrum of abnormalities exist in the trisomy 21 population. Look at what our treatment principles are. How do we choose what procedure and when? And most importantly, how do we try and minimize complications in this challenging situation? To help us with that, we have an esteemed faculty here with experts from all over the world. We have Dr. Eastwar, who is a pediatric orthopedic surgeon from Kerala, India, who's going to start us off, followed by Miss Eastwood, who needs no introduction, and a special thank you to Deborah, because I think it is fairly well past midnight in the UK. So thanks for staying up and doing this with us at this godforsaken hour for you. We then will have Dr. Kelley, who is Chief of Pediatric Orthopedics at Texas Children's, followed by Dr. Millis, who needs no introduction. He's kind of the godfather of hip preservation in not just the United States, but world over. And finally, to wrap it up, we will have Will Morris, who is just a phenomenal human and a very experienced hip preservation surgeon at Texas Scottish Rite. So without further ado, Eastwood, please take it away.
Just a second. All right. Good morning, everyone. Good afternoon, good evening, wherever you are. And we will start with, to understand the problem a little bit, start with what indeed is hip instability in T21. It's not DDH. So that is something that we have to understand up first. This is not congenital. It could be because DDH can co-occur with trisomy, but in itself, T21 is something that evolves as the child grows, and it's to do with the ligament laxity these children have, the hypotonia these children have, but not only that. There is considerable bony abnormalities which are being picked up, like retroversion in the acetabulum. There is considerable anteversion on the femoral side. There is coxa valga. So all these put together create an instability picture, and that tends to evolve as the child ages. And it evolves asymptomatically, and by the time you get to know, it is a fixed dislocation and very disabling for the child. So we'll understand the epidemiology, the natural history, and go quickly through the bony pathology and dwell a little bit on the evidences. So the literature right now suggests that there is about 1 to 7% incidence of hip instability in the pediatric age group. But there is also evidence that it climbs up to around 28% in the adults. So the hip dysplasia kind of increases as the child grows. This is something that evolves as the child grows, unlike a DDH. And spontaneously, the hips can dislocate. 1 in 20 hips can spontaneously dislocate. We have, in preparation for this webinar and otherwise, I've collected all the our cases and went through them, and our incidence seems to be a little less in India. So we will be coming out with our publication soon, but our paper suggests that the incidence of dysplasia in E21, especially in the older group children, seems to be a bit less. There is significant bony anomaly. There is typical appearance of a flared ileum. The ileum tends to be quite a big flare and splayed out. And the acetabular index funnily seems much higher. That is, it seems kind of a flat acetabulum. But there is, on the femur side, there is a considerable coxa valga, caput valgum, if we can call it that, or all those anomalies on the femur side. And on the acetabular side, you have retroversion. And retroversion and poor posterior coverage. These are two anomalies that get consistently picked up. So these children here in the 2 years and 8 years, you can see that these anomalies persist. And in the outpatient, they seem, at least on the supine X-ray, they seem fairly well located. But in India, there is a considerable social stigma attached to these children, especially the girl children, and they tend to get confined into their home, and several metabolic bone diseases, rachitic changes are especially evident, especially for this child, 14 years. She never stepped out of her home. It was kept home confined. I can see the quality of the bone there. So these are additional compounding things that we see locally. So collagen defect, pelvic morphology, hypertonia, and ligament laxity due to the inherent problems in down, and also femoral anatomy. All these mix together to create a potent mix that tends to progress as the child ages and in persons, and it silently leads to dislocation, and it becomes a fixed dislocation many times before it is even picked up. So there is a window of opportunity. There is a ligament laxity, and there is a window of opportunity wherein there is an instability which is flexible, if you can call it that. And that is the time where there is an opportunity to intervene, and we will probably debate as to what that intervention would be. But if you pass that, then it goes into a fixed dislocation, which can become very painful for these children. So they behave in various ways. So take, for example, this 2-year-old picked up as an outpatient regular screening 2-year-old. And in about 3 years of time, about a year, these hips seem to be getting better. I have not operated on this yet, but I'm just closely watching as to how they evolve. So they started off bad and then seem to get better in a year. But so are these hips, which asymptomatic till now and suddenly worsen, and rapid behavioral worsening is noted by the parents. And I'll show you the video where I have kept the sound on for one reason, for the uninitiated to understand how difficult it is to pick up, how difficult it is to pick up. So this is how these children behave, and very often you attribute the bad gait to the flat foot worsening and the behavioral disturbances in down and other things. But really, in trisomy, it is very difficult to pick up the hip pain in many of these children because the communication, verbalization would be an issue. Some of these hips stay radiologically abnormal. You can quite clearly see the retroversion and the low posterior coverage in this 17-year-old who is still asymptomatic. So what should we do about these hips? Should we go in and offer treatment for these hips? But if we do decide not to operate, we have to remember that these go into a functional decline and a lot of changes, and they develop fixed dislocations, which can be very painful. So before it is too late, we have to intervene. And that in itself is the crux of the decision-making issue that we are facing. So what we follow is a newborn screening, a very permissive screening for all the children who do come with T21. We do offer screening, and walking age radiographs, absolutely yes, even though they may be clinically asymptomatic, and it goes all the way up to the adolescent. As of now, the evidence is sparse and not very convincing, but we are including them in the screening to pick up those cases who silently progress. We seem to have no other better way to judge it than take an X-ray, even though we don't have the evidence for that yet. So silent progression, subtle clinical signs, you have to watch out for those little behavioral disturbances in these children before the fixed dislocation develops. It is very, very tricky to assess these children as they have coexisting anomalies like flat foot and behavioral disturbances otherwise. So it's very difficult, and they may attribute the change in gait to those disturbances. So we have to rely on tests and err on the side of the hip and have a high index of suspicion to pick these up. So we have our own team. We have a clinic here, a DS clinic specifically for orthopedics, and we have an entire team which works and sees up. We hope that in coming years that we have more data to share with you. These are my references, and thank you very much. And I think we can now have the ball rolling. Thank you.
Thank you very much, Eastwood, for getting us started in this journey on how to best address the hip in Down syndrome. You've clearly shown us that it is a significant long-term issue, and we have the different stages of the hip becoming more and more unstable and then eventually becoming fixed over time. Just for all of our participants, please send questions into the chat, and we will be happy to go over those as the webinar goes on. If we can have you guys participate, it'll be much easier for all of us to kind of give you little bits of information that may not necessarily be in the talk, because clearly it is somewhat of a limited time, and we will try and cover as much as we can, but the discussion will probably highlight some of the points that are not in the talks themselves. So please feel free to send questions into the chat. I will now invite Deborah Eastwood to help us kind of understand how to best go about with hip screening in Down syndrome. Deborah.
Thank you. As we've heard already, there is a problem with trying to define what we're talking about in terms of hip instability or hip instability associated with Down syndrome. And as has already been mentioned, this has perhaps come to the forefront because of the recent scoping review, which looked at 54 studies of children and adults with Down syndrome or trisomy 21. That reminded us that there was little or no association between the history, the examination, and the X-ray findings, which doesn't really help us when we're trying to define a problem, to identify it, to treat it. It did suggest that the literature would agree that different problems present at different ages. And maybe the treatment of a Down syndrome hip instability has a higher complication rate than our standard DDH. It did highlight, as we've already heard, that adults with Down syndrome and abnormal X-rays will have poorer mobility. And the suggestion was that regular X-rays may be appropriate. So if I set the scene in the system in which I work, which is the UK National Health Service, where we provide a comprehensive, universal, free at the point of use care based on need. And that's delivered through 42 integrated care systems, which are partnerships which bring together the health services, but also the social services, so that we can improve population care and reduce the inequities that some of our kids face. We do have a national screening program, but the problem with screening or having a screening program is that the tests that we're using should be validated and highlight a defined population and pathology for which there is a validated treatment method. So we've had enough trouble in the UK getting a DDH screening program up and running, let alone trying to work out how we might treat the hip in Down syndrome. But all children are examined at birth, and that is documented in their health records. We have a selective ultrasound screening program looking at hip instability, risk factors. So medical concern is a risk factor, but not Down syndrome as such. And all of the details of the scans and the exam are now part of the kid's record. As you know, Trisomy 21 in the UK is our most common chromosomal abnormality. All pregnancies are screened for Down syndrome. It's diagnosed in 2.7 per thousand pregnancies, but that results in only 1 per thousand live births with Down's syndrome. So if we do have neonatal or infant hip instability, well, we follow the guidelines of the Hip Hope Network and the IHDI. We treat as for DDH, maybe for longer. We've got no real evidence, and it is unusual. And to my surprise, when I looked, I could not find a child with Down syndrome presenting in infancy and being treated in our Pavlik clinic. So when do I or we in the UK see them? Well, when we looked at our kids, the mean age of presentation was between 5 to 6, with the classic signs of difficulty walking, tripping and falling, and a clunk, with a hip clunking in and out. And sometimes some restriction in movement, but not often. And of course, then there are the habitual dislocations who love to clunk their hip in and out. And those we could try treating with advice, a bit of behavior modification, far more easily said than actually done. And whilst most people might suggest bracing, I would think all of us have maybe toyed with the idea of trying to brace these kids and found that it's really not very practical as a long-term measure. So in the UK, part of our integrated healthcare systems would suggest that these children do need and deserve community services monitoring along the lines of that guideline. So all our babies are linked into community services, and they have health checks 3, 6 and 12 months, and then annual reviews. And that is supported by, in the UK and Ireland, the Down Syndrome Medical Interest Group, who are beginning, I think, to push harder in terms of looking at hip problems rather than just foot problems. And what does our monitoring system look like? Well, it's all designed at trying to identify the something rather than the nothing, and maximising the potential of all our young folks with Trisomy 21 or Down syndrome. So this, of course, is a complicated pathway. It's an example of a pathway that is used in the northeast of England, but is replicated in many areas of the UK. It's for physio and occupational therapy services for our kids with Down syndrome, the young kids, this one. So for a start off, they have this lovely thing called the Downright Special Group, and that's the physiotherapy, which will have a drop-in clinic for all children with Down syndrome every 6 to 8 weeks. Then, in this complicated flow chart, there are 2 times when they highlight foot posture as a big problem. We could argue about whether that deserves prime mention. There's also 2 times when hip-related issues are discussed, and 2 where cervical spine instability is also discussed. So every time foot, hip and C-spine potential problems are highlighted, and our therapists are asked to look for them. The advice is for any sort of gait problem is to either treat it with flat foot supports and or refer for a hip x-ray and then ask for an orthopedic opinion. All very sensible, and I think that is streamlining our understanding and our flow of patients. But so then the kid comes to me with these unstable hips which clunk in and out. What do I do then? I'm not a mad fan of behavioral management. I'm not a mad fan of bracing. So I prepared this one earlier. Who knows if I did too much, too little, or just the right amount? I believe in this case, who is now fully fledged young adult, that I did it just right. But I should think that was more by luck than by any judgment, and certainly luck at that time rather than true evidence. So I think in summary, in the UK, we are getting pretty close to what that J. Posner article recommended. But the difficulty remains in knowing what to do when the instability is identified and how often we should x-ray. Do we do it yearly, every 2 years, or at certain time points? And I think that will be forming part of our discussion. Thank you.
As always, Deborah, an excellent talk on a not very straightforward topic. So thank you for your wisdom. I do have a question for both you and for Eastwar. As we go about trying to get a better understanding of the pathology and the true prevalence of hip issues with Down syndrome, and then the next step is what do we do with them? How do we best identify these kids early? What are you doing in your center? Ishwar, what are you doing at your center? How do you organize the Down syndrome population? And who does the initial screening?
I am lucky to have the Down syndrome clinic already well established at our place. It's been there for almost 20 years, and it is led by Dr. Shaji, who is a pediatrician here. So there is a large cohort of already existing, well-counseled, well-worked up T21 patients, and they get funneled to our orthopedic clinic. And it's easy for us to explain to them the lack of evidence and leave them, the choice of getting it screened yearly and see how they progress. So we pick them up right at the time when they first get enrolled into the clinic. We have a common outpatient clinic where they walk them through the different specialties and get them screened for all the things. So as part of that, we do get yearly X-rays now. And for those children whom we identify with dysplasia, we keep them under surveillance, just like in the DDH, and we are not sure how these behave. So every 6 months, for those who have a frank dysplasia, I get an X-ray. So basically, lack of evidence rather than it's a bit arbitrary, but that's what I do right now.
And the UK is not that well organised. So we've got it in the community and that's getting better organised. But we are not yet being, not that we'd be inundated, but we're not getting a steady stream at an appropriate age of Down syndrome children coming up with their hip X-ray. So that may be what we need to work for. And maybe, for the sake of 1 per 1,000 live births, we should get them all ultrasound scanned for interest, if nothing else, as a starting point of what their hip pathology might be. So I think we're behind you as well, and maybe we'll get there in the future. But I'm not sure the NHS has enough money at the moment to take on too much more in terms of screening for a population where we don't quite know what to do with the problem that we will identify, sadly.
Yes, I think, Ishwar, just like you, we have our geneticist who runs a Down syndrome clinic, and that is in conjunction with a therapist who are very, very good at musculoskeletal exam. So they're the ones who end up doing a good, thorough musculoskeletal exam to be able to then identify some of these issues. So I think bottom line is we have to partner with our friends and colleagues across various disciplines to be able to see what is best feasible in each individual situation. And then to Deborah's question is how often do we do this? I think as long as they're coming in annually, I think getting them to be looked at annually, just at least to start with a clinical exam, and then maybe every couple of years get an X-ray if there's any question, might not be an unreasonable way to go. Then once you identify things, then we have to turn it over to Simon because he's going to solve the entire problem and tell us exactly what we need to do. Simon, take it away.
Okay, fantastic. Thank you. Well, I'm certainly not going to solve the entire problem, but I will start the conversation about operative management of the hip in T21, and specifically we're going to focus on the role of the femoral osteotomy. So thanks, Mihir, and thanks everybody for the opportunity to speak with you guys this evening. And so we're going to talk really just one side on the pathoanatomy and how that plays into the role of the femoral osteotomy. Just I'll touch on femoral versus acetabular surgery, understanding that we've got talks on acetabular surgery afterwards with Dr. Millis. I'll give you a couple of technical tips on how we approach femoral osteotomy and then something on the outcomes of that procedure. And so we've already heard why hip instability matters. It matters a lot because we know that untreated instability is devastating. It leads to stiff, painful, and dislocated hips. It takes ambulatory kids to become non-ambulatory adults. And we know that early intervention is going to improve long-term function. So, surgery is often the way. And what's really important is what we've heard about the pathoanatomy is this drives the instability. So we've heard about the profound ligamentous laxity, but regarding the femur, we've got our increased femoral anteversion. We certainly have an increased, or at least an apparent increase in the valgus neck shaft angle. Of course, the rotation of your x-rays makes it difficult to measure sometimes. There's a primary acetabular retroversion. And again, we've heard that soft tissue procedures only, or soft tissue only procedures generally fail in this condition because there's, again, profound bony dysplasia. And that's what we need to tackle if we're going to stabilize these hips. So the goal of treatment regarding surgery, then, we want early stabilization. And the reason we want to get these hips stable early is because we've heard about this primary acetabular retroversion, but with ongoing instability, you start to see really this sort of secondary dysplasia as well, the femoral head sort of grinding in and out of the acetabulum, wearing it away, increasing acetabular index makes the hip more unstable, and the whole bony pathology becomes more complex. And so our goal of treatment then is to, not just stabilize the hip, but reduce the chance of getting later degenerative disease and, as I said, prolong ambulatory status. And then we can get exceptional functional outcomes as long as we approach it aggressively and early. So where does the femoral osteotomy fit? So I think it fits in the really young kids. So these are the children in the habitual dislocation phase. If I have to give you an age, it's kind of the under eights. Of course, nothing's ever as clean as a single age, but just to give you a sense, it's the younger children with habitual dislocation. They've all got this marked femoral deformity, and generally at this stage, they haven't developed that secondary acetabular dysplasia on top of the primary retroversion. And so, when we're thinking about, femoral osteotomy versus acetabular only, what I'm thinking here is that by performing a femoral varus derotation osteotomy, we can address the primary femoral deformity, and we're using that, and I'll talk a little bit about that, correcting the biomechanics or overcorrecting the biomechanics in these hyperlax hips, using the bony correction to account for that laxity. We can get excellent stability using this technique in young children. I'm going to defer the comments about the acetabular osteotomy because we're going to certainly hear about that later. So technical pearls then for a femoral derotation osteotomy. So first thing, typically is a fixed angle device. I've always used a blade plate. I find it really helpful because these children, morphologically, they have very sort of long, gracile and narrow femoral necks. And so a blade plate is a nice device to use. And what's really important about these is you really need a lot of varus. So the target neck shaft angle is going to be 105 degrees, plus or minus 5. It's very different to DDH where, just a modest amount of varus or modest amount of anteversion correction is the way forward. Whereas with trisomy 21, you need a more aggressive correction. So we're really over-correcting Shenton's line effectively. You do want to maintain, a decent amount of anteversion because, of course, we've heard about the acetabular retroversion, and if you over-derotate these hips, then you can actually worsen the posterolateral instability. I will also find that even with pretty aggressive varus femoral osteotomies, they still need some post-op immobilization. And I would typically use Petri cast, which is, two long leg cylinder casts with a bar between them, just to hold those hips in abduction for 2 to 3 weeks, really just to let the hip settle down post-op. I find that's quite effective. So there's 2 papers here. If they're of interest, there's QR codes. One is a review and sort of an oldie but a goodie. I wrote this with my senior mentor, John Wedge, probably about 12, 13 years ago, but really just to have a look at the literature at that time. And then the second paper is Dr. John Wedge's experience of using the femoral varus osteotomy in these young children. And I'll give you a synopsis of that now, in that his results in, clearly a relatively small series, but all of these kids were 5 to 7 years of age. They all had habitual dislocation. They all got a sole varus derotation osteotomy of the femur, no acetabular surgery, bringing down that neck shaft angle to around about 105 degrees plus or minus. And the results were pretty good. There were no redislocations, and in the longest term follow-up of that paper, they were all independent ambulators. So, femoral varus derotation osteotomy is quite an approachable operation for most pediatric orthopedic surgeons, and started early, it can be quite effective. A couple of things to note in terms of femoral osteotomy, well, any operation really, but specifically with femoral osteotomy, is the peri-implant fracture risk. Remember, these kids are a bit osteopenic, their bones are a bit weaker, they're gracile, fragile, and there was a higher than one would expect rate of peri-implant fracture about the blade plate. So do take the hardware out, and that will hopefully minimize that risk. And the other thing is, we think these kids may have a higher infection risk. There's some sort of humoral and cellular differences in these children. And so it's just a word to always think about meticulous perioperative care to keep that infection rate as low as one possibly can. So what do I do? Early identification and close surveillance. I think we're hearing a theme throughout this evening. And so we try and keep an eye on these hips. I have a low threshold for x-raying the hips of children with trisomy 21 in my clinic. I like a femoral varus derotation osteotomy first line for habitual dislocation. I avoid isolated soft tissue procedures. There's a genetic abnormality in those soft tissues. You're not going to correct it by doing a capsulorrhaphy. And in terms of adding acetabular corrections, these will be the older kids, only when there's significant dysplasia present. And so really what we've got here is an emphasis on trying to develop a durable, long-term, stable hip. So the simplified algorithm, young kids, femoral varus derotation osteotomy, older kids, further progress of their acetabular dysplasia, think about adding an acetabular osteotomy. But then you get to the teenagers who maybe have either had failed treatment or no treatment, where they have degenerative joint disease, and arthroplasty is actually a really good option for those. There's some good literature supporting that. And that's it. So thanks very much for the opportunity to speak, and I look forward to the rest of the talks.
Thank you very much, Simon, for that very clear and concise talk on the femoral side. Now I will invite Dr. Millis to talk to us about the acetabular side of things, and then we can have a little discussion.
Thank you very much, Mihir. Simon, excellent introduction to what I'm going to try to say here. All right. Can you all see my screen okay?
Yes, sir. It's perfect.
Wonderful. Good. All right. So I was given 8 minutes, 7 minutes, 6 minutes and 50 seconds to talk about pelvic procedures, why, when, and how. This won't answer everybody's questions, but it will give you some of my thoughts and tips about how to proceed in this difficult group of patients. First of all, I'd say we all know this, who take care of kids with trisomy 21. You must have a checklist because the comorbidities are almost universal. There are multiple contributors to abnormal hip function, both static and dynamic. And let's just face it, complications or surprises will occur. So backup plans are absolutely necessary. Why do we operate? Well, we've all talked about this a little bit, but it's basically to treat a major clinical problem not otherwise solvable. And the assumption that we have when we're doing surgery is that the treatment will be better than the status quo. You must have a good treatment plan. You hopefully have correctly characterized the instability, which is not always easy. You've mechanically and biologically decided what a sound intervention is. Does the plan make sense to you and experienced colleagues? Is there literature to guide you? And you think you can execute the plan well? And this is also important, the family understands and will help, because there may be indications in a hip, but sometimes the global situation is just inviting disaster. So you have to ask yourself, can the patient be controlled enough to avoid complications from behavior? We can't always control this factor at all. So when do you do a pelvic procedure? Well, Simon has given us an excellent introduction. Basically, it's the need for better acetabular-based hip stability. And we have to understand the acetabulum may be normal in some cases that require acetabular surgery. Simon, I don't disagree with your thought that you'd like to see some acetabular dysplasia to be thinking about an acetabular procedure, but sometimes it looks normal, it may be normal, but you need that hyper coverage just because of all the other things that are going on. Unstable Down's hips do usually have acetabular abnormality, but I'll admit I have sometimes done acetabular procedures in kids whose acetabulum really looked and seemed normal just to get that extra bit of coverage. We can't say enough, the acetabulum in Down syndrome is often, not always, often retroverted, and this is not always easy to see. The assumption is when we're doing a pelvic procedure that Simon's algorithm is insufficient. Often, a femoral osteotomy will take care of the problem, but we have to be prepared to do something on the acetabular side. Now, doing something on the acetabular side might not be enough either, and sometimes combined procedures are necessary. So how do we do these procedures? Well, I'm trying to decide first what's required mechanically. There are two basic types of acetabular procedures. There are augmenting procedures, which means a shelf or a Chiari, or there are realignment procedures. And in terms of the realignment procedures, pediatric orthopedists are very familiar with the Salters and the Degas. Those are, quote, simple or incomplete osteotomies. They bend, they realign the acetabulum, but they're not really totally reorienting it. We found in Trisomy 21, you sometimes need a complete osteotomy, which means a triple in a younger kid, or a spherical RAO, TOA, or PAO in the older kid. The advantage of those procedures is that you can rotate in any direction. And no matter how San Diego-y you try to be with putting posterior bone graft in, sometimes it's tough to deal with posterior insufficiency with anything less than a complete pelvic osteotomy like a triple or a PAO. Woody Sankar was our fellow when we looked up a very interesting group of patients and showed pretty conclusively that in a high number of Down's unstable hips, there was acetabular retroversion. So we should always be looking for the acetabular walls, but understand in the young kids, it's sometimes tough to see the walls. So what just looks like pretty solid, good lateral coverage is really acetabular anterior hypercoverage and posterior insufficiency. So sometimes you have to get CT scans to see this. This is a 7-year-old. This was a kid who came in to see me. This was our first anteverting triple osteotomy we did. This kid came in and was posteriorly unstable. And I wasn't really so aware of the retroversion at that time, but I kept looking at this and I said, the coverage looks so good. How can this hip possibly be so unstable? Well, I got the CT scan and the posterior view shows you're looking right into the acetabulum. And from the anterior view, it's really hyper covered. So the fact was that this kid's anterior coverage was too good. She was impinging in flexion and dislocating posteriorly. So this was our first anteverting triple. And we went on to write, I think, an important paper looking at the results of our incomplete osteotomies, namely the Degas and the attempts to do San Diegos and the Salters and the anterior shelves that just didn't work so well in these tough hips. Whereas the PAOs that anteverted and the triples that anteverted seem to, more often than not, solve the problem. So tips to remember, combined femoral and acetabular procedures are often needed. The last point I want to give you is that Chiari osteotomy is a stronger, tougher, more robust shelf that sometimes you need for these very nasty, very dysplastic hips. This is a kid who came to me much later than I wanted. You can see she had Salter-type osteotomies. You can see the anterior iliac defects up on the pelvis, and neither hip looked very good. The good news was that on the abduction views, the femoral heads went down into something, and her movement was quite good. She wasn't stiff. That was the good news. The bad news was it was still a very bad problem. Well, I decided that on the left side, she needed a Chiari. And so that's what she got. She got a Chiari. The very long-term results of Chiaris have been recently written up by Katerina Chiari, who is Professor Carl Chiari's granddaughter. Long-term, ultra long-term results, minimum 35 years follow-up. That's pretty good. Now, these were not all Down's hips, but still the results were quite good in this group of patients. So remember about the Chiari. I don't have time to talk to you about the details of technique, but don't forget it. It can be a very good operation. So this kid ended up with a Chiari on the left side, and later on, the right hip got its turn. It was a better acetabulum, so I did a PAO and a varus shortening osteotomy. Now, she is not great. She's not an Olympic athlete, but I talked to her mom recently, and now she's 11 years post-op, and she's had no further surgery. So these are tough hips, and there's no good answer for all of them. But think about the pelvis. Remember the retroversion. Don't forget a Chiari osteotomy for these very dysplastic hips. So my summary on pelvic procedures is determine if you can in 3D the major direction of the instability. It's often posteriorly, but they're not all retroverted. Sometimes a Salter osteotomy may be the right thing. Assess the anatomic situation in the patient. Remember, you can't see the cartilage. So in these young kids, you got to be looking at the walls particularly. Does the patient age affect decisions? Yes. I would point out to you that you can do PAOs on these kids down to about age 9. And sometimes a PAO will work and get better correction than a triple. The little kids, you got to consider a triple instead of a PAO. And lastly, my most important point is discuss cases with experienced colleagues. So with that, I'm going to stop and turn it over to Salil, who's going to solve all the problems that I am not able to solve.
All right, so you are up, and you're going to
right.
tell us how to minimize complications, because clearly even Dr. Millis says that he has some, so the rest of us are okay having some complications in this difficult situation.
Yeah, absolutely. Thank you. Thank you for inviting me for this webinar, and thank you for the opportunity to air my dirty laundry in front of the hip gurus who taught me how to do hip surgery. So, Dr. Millis, I apologize for all my complications. I swear I know how to do hip surgery, just not in Down syndrome patients. So
We've all got them, Salil.
all right, so before I get started with this, as any good incompetent surgeon would like to do, let's blame some of the pathophysiology in these patients. So all of these patients have a lot of hypotonia. They have joint hypermobility, ligamentous laxity, and delayed healing. Professor Ben Allman was a visiting professor in Rades a few years ago, and he burned this image into my brain. So collagen 6, the genes for collagen 6 actually live on chromosome 21. And so when you have 3 copies of collagen 6, its primary function is to act like those metal chains holding the logs of collagen 1 in order. And if you have malformations in that collagen 6, you can imagine the chains breaking loose and collagen 1 falling apart. So that's basically what we're dealing with in these patients, causing the ligamentous laxity and all the healing issues that we have. And then the other speakers have alluded to this, but it's very true. These patients either have higher pain thresholds, or it's extremely challenging communicating with them or encouraging them to follow our postoperative restrictions. So symptoms in these patients present very differently, and it's really important to use their family members to communicate well with them and understand their symptoms, because their symptoms don't present like the typical patients that we're used to taking care of. So I have published some on this topic along with Dr. Wenger. Again, single center, very small series, so goes to support the rare hip registries that are being started in Vancouver with Kish's help. We really need to put all our patients together to learn from each other and figure out ways to improve our treatments. But basically what this study showed is a very high complication rate, right? Almost 50% complications, 32% that required secondary surgeries. But fortunately, despite all of these issues, the patients have functionally good outcomes and we're maintaining their ambulation. And I think that's ultimately the goal of treating hip instability in these patients. So in this talk, I wanted to focus on some of the most common issues that we have. So recurrent instability, delayed unions, non-unions, as well as avascular necrosis. Before I get into my dirty laundry, I wanted to show Dr. Millis that I can do some hip surgery. So this is a 10-year-old male down trisomy 21 with left hip instability. Again, a 3D CT is extremely important to understand the femoral as well as acetabular pathology. I thought the femur was actually reasonably aligned, so I decided to focus primarily on the hip. None of the other speakers have focused too much on this concept of open reduction and capsulorrhaphy, and I think there's a lot of debate whether tightening up pad loose tissue adds anything to getting the hip more stable, but this patient did undergo an open reduction as well as a triple innominate osteotomy and increasing that posterior coverage like we learned from Professor Millis. So this is him at 2 years post-op and at 5 years post-op, maintaining his ambulation, maintaining the stability, and fortunately no complications in this one case. But now let's talk about all the other complications. So I think some of my takeaways from the previous speakers, instability in these patients doesn't present like DDH. It's typically not present in infancy. It typically develops in childhood. So we do start monitoring, screening these kids in somewhere around the 3 to 5 year range. Most of the time, they present because of habitual dislocations. The family or the pediatrician is feeling a hip click, hip instability. And when a 3-year-old or 5-year-old with trisomy 21 presents to my clinic with hip instability, it makes me throw up because I actually don't have any good solutions for these hips, right? So this is symptomatic for the child. The hip is sliding in and out of the socket. So this was treated a number of years ago with just derotation osteotomies as well as a Degas type procedure or a San Diego acetabuloplasty for the right side. And over time, so this is at 8 years old, 5 years post-op, you can start to see recurrent instability occurring in both hips, starting on the right side and then becoming more symptomatic on the left. So similar to cervical surgery that I do for trisomy 21, C1, C2 instability, I almost prepare the family that there is going to be a revision. My first attempt at stabilizing the neck is just trying to get extra bone into that area. And then when the child gets older, that's when we can get some instrumentation in there and get the fusion. Similarly, in these young hips, I feel like recurrent instability, especially if you're going to operate under age 5, is almost guaranteed, and you're going to need to readdress it when they're closer to skeletal maturity. So this patient underwent just a removal of instrumentation distally on the femur and then a triple innominate osteotomy on the left side, followed by a similar procedure on the right side with a PAO because the triradiate cartilage was closed. And then here she is 3 years post-op from that PAO at 16 years old. So number one problem, recurrent instability, very common if the initial surgery is done in childhood. The next very common issue that I have is non-unions. In this case, I'm going to present an ischial non-union, but I've had a number of femoral non-unions actually, which result in multiple revision surgeries, ultimately resulting in some kind of long, femoral spanning implant like a intramedullary nail or a rush rod. So this is a 9-year-old male with instability. Again, a CT is extremely important to understand the anatomy. Underwent a VDRO, derotation, varus osteotomy, as well as a triple on the left side, went on to heal that beautifully. We went to address his right side 6 months later, had the similar procedure with VDRO and a triple. And you can see a year later, the left side is healed and he has a non-union on the right side. This is when I reached out to Dr. Millis. I don't know if you're going to remember this, but I dug into your paper on triples. There was a not inconsequential number of these non-unions. Most of them are fortunately asymptomatic. So I really tried to convince these parents that don't worry. I know it looks different from the left side. Your kid is going to be fine. But the mom just was not happy with that answer. So when I went in to take the implants out, I did revise the ischial non-union with bone graft as well as with some BMP and this screw going up through the ischial tuberosity. Here he is 4 years post the revision. I don't know if it's fully healed. There's a little bit of lucency at the pubic osteotomy as well. But again, he's asymptomatic, and I can definitely feel that head of the screw on his ischial tuberosity. So I don't know if I've done him any favors, but again, still ambulating and relatively stabilized. And then another very common issue, avascular necrosis. So this is a 14-year-old male with hip instability, treated aggressively with a triple as well as a shelf and a VDRO, along with an open reduction and capsulorrhaphy. And he went on to pretty early osteonecrosis of the femoral head at 1 year's post-op. But again, these kids are different from the typical population. And here he is 9 years post-op, still ambulating on that head. Obviously, the joint doesn't look fantastic, but he's surviving and has not gotten a total hip. So I think our expectations just have to be different with this population. I think ultimately we're trying to get the hips stabilized and keep them ambulating, and just preparing the families for the long journey ahead and getting, very close with them in terms of helping them understand the issues that you're going to go through with hip preservation. So take-home points is a challenging patient population and pathology. Really try to understand that 3D anatomy, like we've all said. Over-containment and prolonged immobilization is your friend in this patient population. And despite high complication rates, I think we can still get good functional outcomes. Thank you very much.
Thank you, Salil. That was a great talk. A lot of key points for us to take away. I think the most important thing, as you pointed out, is to have family buy-in and help them understand that this is a journey. Just because you operate on somebody at age 5 doesn't necessarily mean that you're going to be done. As you pointed out, very frequently, repeat instability over time does tend to develop, and that needs to be addressed, especially around that adolescent growth spurt. So I think getting the family on board early on with that concept has been really helpful to me as well. So thanks for pointing that out. The one question that we are getting in the chat is you brought up capsulorrhaphy and capsular tightening. Can each of the faculty tell us if they believe in capsular tightening, and if so, what is the best indication to advocate for a soft tissue tightening in conjunction with their bony procedure? Because I don't think any of us would do a pure soft tissue procedure. So can we start with Eastwood?
Just like I think most of these ligament laxities, if you're going to open up the capsule, it's going to go again lax. I mean, you can imbricate it, but along with a bony procedure, but it has to be, the bony procedure has to take precedence over the ligament testing, because you can't beat genetics. It's going to stay lax no matter how tight you're going to stitch it up. It's just going to pull loose again. So you're going to back it up with a bony procedure.
Great. Deborah?
I do like a capsular tightening. I have to say, you've got a very distended capsule. You can see that it's very distended. You can improve the bony anatomy, but I think I personally am not happy to leave it without doing some capsular tightening. It may stretch out. I don't think it always does. I think, there are some stable hits which don't have a lax joint later on. So yeah, I do it because I think at the time it adds extra support to my bony correction in terms of giving some soft tissue stability, which may or may not last.
Simon?
I feel similarly to Eastwar, actually, that you can't beat the genetics. I think if hip stability is best dealt with bony procedures, and as we've heard, more acetabular coverage than you might typically do, the same as I mentioned about femoral osteotomies as well. So it's pretty rare. But I don't think it's wrong. I think we've all agreed that there's no real role for a soft tissue only procedure. I'm just not convinced it actually adds much, to be honest.
Dr. Millis?
I think I'd do it if the hip were dislocated. I've almost never done it. In truth, I do have a couple of comments about the Salil's paper, which is great. I'll just sneak in a question of him. Well, an answer, a comment. The triples can get non-unions, Salil. And, I haven't stopped doing triples, but I think you have to be very careful about the ischial osteotomy in particularly, and the superior ramus osteotomy. So in the 8 to 9-year-old kid, we've really gone to PIOs because I think the risk of non-union is just simply less, because I think sometimes they are symptomatic. I thought your talk was great. So I don't do capsulorrhaphies very often, And I think Salil's approach to complications is a terrific one. Very honest, very sound.
Salil, do you do it routinely, or are you more selective in the ones that you indicate?
Yeah, so I'm migration index more than 50%, so not just fully dislocated, but severely subluxated too, similar to Professor Eastwood. I think tightening up that tissue, at least in temporarily, does something. I also do ligamentum teres reconstructions in those hips. I am still keeping the ligament intact, tightening it back down, either medially into the adductor fascia or into the acetabulum itself. I know some people are using like an endo button type of implant to reconstruct the ligamentum. I don't love having suture in there. I would rather use native tissue, even though it's pathologic, but that's just my bias. No great data for that.
Will?
I'd say selectively we'll do a capsulorrhaphy, and generally after, if you're doing a acetabular sided procedure like a triple or a PAO, after you've gotten your correction and fixation, I'll see how the hip is moving. And I've noticed that even in the same patient, if I'm doing bilateral surgery, on one side that may have been more affected, even after you've achieved a lot more anteversion and coverage, you'll still see a rollback where it seems like there's still translation within the socket. And that's a patient where I'll do a limited capsulorrhaphy without taking rectus down, almost like an L-shaped leaflet that I can pull over and snug it up, imbricate it, which I think is what Dr. Eastwar had mentioned. So that's my preference, but I don't have any data to support that that's better than any other approach. Can I ask a real quick question? And this can be even just a one answer from each member. We haven't really talked a lot about immobilization. Simon alluded to it after he talked about the Petri cast. If you're doing a pelvic sided procedure, is everybody immobilizing their patient? And if so, what are you using it for how long?
So I'll probably go first. And typically, if it's a young patient, I am more than happy to stick them in a spica. The adolescent who is, 120 kilos is a little bit harder to put in a spica. So they will get a custom brace that we fabricate ahead of time. And, obviously they'll take it off for hygiene and other things. But for the most part, we'll leave that on for a good 4 to 6 weeks. Dr. Millis.
For kids who are maybe under 6, especially if I've done bilaterals, femoral osteotomies, I'll put them in a bivalve spica for 3 or 4 weeks, I think that the older kids is just a nightmare. In a behavior problem, you don't solve it by putting them in a spica. But this is something you decide with the parents beforehand. I think that, but the younger kids, yes, I'm not averse to putting the kids in a spica because I think that helps reduce your risk of delayed or non-unions. It's not unheard of, Salil. It's not just you. The bone isn't so good. The biology is not so good. So I think sometimes the spica for a few weeks can make a real difference.
Salil?
Yes, I use spica as well, even up to 12 or 13. We prefer the waterproof material, so single leg spica for 6 weeks, even in older, heavier kids.
Deborah?
Yes, I would similarly, I quite happy to use the spica cast. In the older kids, I sort of wax and wane between some of the different sort of commercial hip braces, and then sometimes I think that the Petri casts with an abduction bar are just as, in fact, more comfortable and easier for the families to cope with.
Simon, are you an exclusive Petri person?
Yeah, I don't use a spica. I remember being told that if you don't put the Petri on, that you go see them post-op after the case and they're already lying there with the legs crossed, trying to redislocate the hip that you've spent the last couple of hours putting back together. So I think it's as much support and behavioral just for that first 2 to 3 weeks with the Petries in the younger kids, of course. I haven't treated that many older kids, but I haven't actually braced them. But I just never felt it was necessary to go full spica, and the Petries are actually very effective. I mean, we can argue whether it's more or less awkward than a spica cast, but at least they can sit up a bit more easily. So I like the Petri for a few weeks afterwards.
Eastwood?
For the older children who are also very heavy, Petri cast is what I do. And for the younger ones who can be contained in the spica, I put the spike a minimum of 6 weeks, and I prefer to change them based on my intraoperative, how it was, how stable I felt, and how I thought, it lousy it was. I prefer to induce a contracture and put them longer, maybe like 3 months or so in the spica, change them once in between. That's my best bet. I don't know otherwise how to retain them inside.
Yeah, I think it sounds like all of us tend to err on the side of caution and try and immobilize one way or the other for at least a few weeks. So I'm glad there's some consensus to that. Um, I think we can keep talking about this for the next hour and a half if we had the opportunity. And Joel's been kind enough to let us continue on well beyond our hour. But I do want to have Will share his experience with the non-dysplasia, non-instability hip issues that we also see in Downs. And these are a unique set of problems with their own particular complications. So, Will, enlighten us on those, please.
All right. Well, thank you very much, Mihir and Joel, for Hip Hope to give me a chance to chat about the one talk tonight that is not hip dysplasia. But I think this is really important because, again, whether Salil has now scared you away from managing hip instability or not, you're still going to have to meet this patient on call. And so we're going to speak for the next few minutes about slipped capital femoral epiphysis or slipped upper femoral epiphysis for our European colleagues. And then we're going to touch very briefly on Perthes because there's very limited literature in that area. But we'll look at differences and similarities in the patients in terms of the incidence, treatment, as well as outcomes. So let's come back to our young man who is a 14-year-old with Down syndrome who was transferred from an outside hospital in the middle of the night with an inability to bear weight and these radiographic findings that together were consistent with an unstable slipped capital femoral epiphysis. And so I took him urgently to the operating room, got him positioned on a fracture table where just with some gentle traction and internal rotation to put the patella towards the ceiling, what we used to call a serendipitous reduction, the epiphysis reduced back essentially anatomically and stabilized the epiphysis with two fully threaded 6.5 millimeter screws. And at this point, I think the most important step was then a capsulotomy. I use a Cobb elevator you can see outlined underneath fluoroscopic visualization. You can use any tool you want, a long-handled blade or other elevator. But I think this is really key for two reasons, and particularly in our Down syndrome population. Jose Herrera Soto showed us that clinically, there's increased intracapsular pressure and unstable slips. He noted that in the patients that underwent a gentle manipulation or reduction, kind of like placing a patient on a fracture table and internally rotating the hip, that the intracapsular pressure went as high as a mean of 75 millimeters of mercury. And Salil actually built on that work with a study in a porcine model where he showed that increase in the intracapsular pressure to about 30 millimeters of mercury above the mean arterial pressure could actually result in tamponade of the epiphyseal perfusion. So if you take that clinical and animal model data together, it suggests that increased intracapsular pressure and unstable SCFE can result in tamponade of the vessels in AVN. So I always ensure that I'm performing a capsular decompression in unstable slips. And I think that's particularly important in our Down syndrome population because any of the tools that we think of to treat AVN once it's established with core decompression, epiphyseal drilling, closed bone graft epiphysedesis generally require some prolonged non-weight bearing to try and prevent collapse of the head. And that's not going to be as successful in our Down syndrome population. So once we've done the capsular decompression, how can we confirm that we have an adequate capsulotomy? Here, Tim Schrader published a nice technique in 2016 to utilize an intracranial pressure sensor threaded in the epiphysis to monitor for epiphyseal perfusion. And so placing that sensor through the cannulated screwdriver into the epiphysis gives us the appearance of a waveform that's synchronous with the cardiac monitoring that you can see there in orange. And it's a nice way to help ensure that you've adequately opened up the capsule to see a return of that perfusion. I think the next important decision point is what to do with the other hip. If the patient's presenting with unilateral disease, I'd recommend a very low threshold for contralateral pinning. I think at this point, I'm pretty much going to pin the contralateral side in every patient with Down syndrome who's coming in with SCFE for a couple of reasons. The first is that there's a high rate of bilateral disease in trisomy 21, and that's probably due in part to the fact that there's high rates of concurrent hypothyroidism, which we'll touch on in the next slide. So in this case, we placed our screw and assessed an approach withdraw technique to demonstrate that we had our central position and that the screw was never extending out of the epiphysis. And finally, I am a glutton for punishment, and so I'm going to place all of my patients into a spica cast, regardless of age or size, for 6 weeks to try to protect them. Particularly and mercifully, this young man was rather svelte, but we placed him in a cast. So keys for successful pinning of Skiffy and trisomy 21 patients, I'd say I'd use 2 fully threaded screws for unstable slip, and honestly, I'd strongly consider 2 screws even in stable slip because there's a high rate of slip progression, which we'll see. A capsular decompression with perfusion monitoring to ensure the adequacy of that decompression, having a low threshold for contralateral pinning, and a spica cast for 6 weeks. So what does the literature actually tell us? Well, we learn a couple of things when we look at the existing studies. One, that the rate of Skiffy in trisomy 21 is much higher. It's about 1.3% compared with 0.01% of the general population. And that's again due in part to the fact that there's a high incidence of concurrent hypothyroidism. I pooled these 2 papers you can see above, and you can see that the rate of concurrent hypothyroidism was 44%. And perhaps more alarming, the rate of unstable slip, patients who weren't able to weight bear on presentation, was 50% in the trisomy 21 population. Consequently, the outcomes were not rosy and complications were common. Slip progression was seen in 2/3 of the patients in the Scottish Rite study from Bosch et al. And the rate of AVN was 41% in those patients that had at least 2-year follow-up. Most of the patients also underwent some form of revision surgery. So consistent with what Salil showed us, this is also a more challenging procedure in the Downs population for Skiffy. And the majority of those were for slip progression, like you can see in the example on the right. We have very little data about Perthes disease in trisomy 21. We do know a couple things. One is that it's more common in patients with trisomy 21. In this Danish registry of almost 2 million children, we saw that there was about a 12-fold relative risk of Perthes in patients with trisomy 21. However, given how rare Perthes is, that still corresponded to only about a 0.1 or 0.2% incidence in the Downs population. And this is the only clinical outcome study on Down syndrome and Perthes, actually coming from Dr. Thacker's institution, that looked at 7 hips and 6 patients that presented with pain, limp, or limited range of motion at a similar age, mean age of around 6 years of age, like we see typically in Perthes. And most presented in the earlier stages, Waldensstrom stage 1 or 2 of Perthes disease. But unfortunately, they also present with more severe disease. And so you can see that 71% developed severe collapse or lateral pillar C. And I can't really comment on the outcomes of surgical treatment as all of the patients in this study were treated symptomatically. Now, in solidarity with Salil, I wanted to show you the outcome of the case that looked really good when we had the cast on. And so today, in this first image, we're taking the cast off and we're following them. And for the first 6 months or so, everything looked great. But unfortunately, the patient developed some sclerosis in the femoral head and eventually collapsed despite the really promising signal that showed pulsatile perfusion with the intracranial pressure sensor. And I think this is just an important point to leave with, that although that sensor may be helpful in guiding your capsulotomy to feel that you know you've at least decompressed the capsule and are leaving the operating room with what looks like epiphyseal perfusion, there are a number of studies, including this one from Woody Sunkar, that demonstrate that having a perfusion signal with an ICP monitor is not 100% accurate. And so laying crepe with the family, even after you leave the operating room, is important. So the take-home messages for Skiffy are that A, this is a common problem at 1.3% incidence in the Downs population, and unfortunately presents very frequently, 50% of the time in the literature, as an unstable slip. You should have a low threshold for contralateral pinning, given the high rates of bilateral disease as well as concomitant hypothyroidism. And you need to monitor post-operatively for slip progression, which is quite common, as well as AVN. Perthes disease is only relatively common, 12-fold increased risk, but again, only about 0.1% incidence, but does present with an increased severity, as usually becomes a lateral pillar C or severe collapse, and was generally treated symptomatically. These are my references, and look forward to the end of our discussion. Thank you.
Thanks very much, Will, for helping us see the other side of the Down syndrome hip, which doesn't seem to be any happier than the dysplasia side. So, we've had a great session today with all sorts of different things about the Down syndrome hip. And I think it would be safe to say that there's a lot more to learn about the Down syndrome hip. What we really haven't really even started scratching the surface about is what really is the pathophysiology of the hip instability. How does the ligamentous laxity plus the pathoanatomy come together to give us an unstable hip, whether it's one side or both sides? How much is impingement? How much is instability? How do they interplay with each other? So lots of things for us to think about. But what we do know is we do need to look at these kids carefully, and we do need to partner with some of our colleagues to be able to come up with some sort of a screening program, whether it's at a local institutions, which might be the best way to start, and then potentially show the results of that to our national and international bodies to see if we can come up with some sort of consensus and build some evidence towards getting a protocol going. So thank you very much to the faculty for taking the time and enlightening us about all the different facets of the hip pathologies in trisomy 21. Thank you very much to the audience for their participation and great questions in the chat. I think this is something that we will need to continue as an ongoing conversation. And we will have, hopefully, we can get the Hip Hop Network to help us out with creating a place or a forum for us to have ongoing discussions, because clearly there's a lot to be learned from each other's experience. So thank you very much, everybody, for taking the time, and I appreciate you very much.
I'll just also sit back and thank, the entire faculty and especially Dr. Thacker for helping bring us all together. So this was terrific. We indeed look forward to following up. We'll have the recording go out with some opportunity for feedback, and we'll look at ways to help facilitate ongoing discussion. So thank you all once again. And I will just share really quickly that we've got our next, and I'll open a slide really fast. We've got our next webinar set up for March. So that'll be with Dr. Emily Schaefer. She'll be speaking about the research toolkit. We have a lot of resources on our Hip Hop Network website. So that's coming up, and we'll watch for the open of the, set your calendars, and we'll set the registration up for that. Also, a reminder, we've got the symposium coming up in September. I think everybody's aware, and so there's a lot more information and registration details. And one quick reminder that the abstract window is open for the symposium through this weekend. So if you haven't already, please do look to that for information about submitting any relevant research. There will be a lot of presentations throughout the symposium. And finally, lots of ways to stay connected with the Hip Hop Network, if not already. So thanks again, everybody. We're very grateful for everybody's time and expertise. Look forward to the follow-up.
Great. Thank you. Take care.
I would like to thank our distinguished panel for sharing their knowledge and experience with us on this challenging topic. What we have learned is hip issues in Down syndrome continue to be a challenge. We do not really have great data to have a true prevalence of how common hip problems in Down syndrome are, especially the prevalence of slipped capitofemoral epiphyses, as well as the Perthes disease like changes that we see in some of these patients. From a hip instability perspective, this remains to be the most common problem, and we do have significant challenges with this. We do not have a great way to screen these patients, although all of us agree that screening would be worthwhile, and picking these patients up early and trying to deal with their hips early may be the best way to go. We need to partner with our colleagues, our genetics friends, our pediatricians, and our physical therapists to come up with a locally viable screening mechanism And once we demonstrate good success with this, then we can present this to the national societies to see if we can get this incorporated into the Down syndrome guidelines. Surgery is the mainstay of treatment of hip instability in these patients, and bracing is of questionable benefit. We do know that soft tissue surgery alone is not a great option because the recurrence rates are very high. So bony correction, especially creating a little hypercorrection even from a bony stability standpoint, is probably the best way to go. Whether we do this on the femoral side and shoot for a neck shaft angle of 105 degrees with a very, very judicious outlook on derotating the femurs, or we do this on the pelvic side, oftentimes with a triple innominate osteotomy or a periastabular osteotomy, given the fact that many, although not all, of these patients have acetabular retroversion? Or do we go with a combination of femoral and acetabular procedures? Some of this really depends on the individual patient's anatomy and surgeon comfort, and we do need better data to have a sense of what our outcomes are like. Because even with the most experienced of surgeons, we know that hip reconstruction in this patient population presents significant challenges and is associated with complications fairly routinely. It therefore becomes important for us to involve our families and educate them about the nature of the hip problems in Down syndrome, and also involve them in decision making as far as interventions go, giving them the most realistic expectations possible. The less common hip pathologies such as slipped capital femoral epiphyses are no less daunting because they do present late. There is a high prevalence of unstable slips and also potentially a high prevalence of avascular necrosis, though we really don't have great numbers to show any of this. And therefore, I would put in a plug for the Rare Hip Conditions Registry, which we will be starting the Down Syndrome Registry in several months from now. And I would encourage you to join this registry and share your data and your experience so all of us can make better choices for our patients and families. So thank you very much for being with us, and please feel free to continue this conversation either online or via email or in person.